So welcome to this symposium. It's my pleasure to welcome you to this BRCCH symposium. And Dorothée Bentz will be the first she will have the first presentation. And she's a professor at the University of Basel, or lecturer, yes. And she will have a talk on the virtual reality and online interventions. And I think it's easier if you introduce yourself just briefly. And yes, so welcome to the symposium.
Thank you very much, Delphine, for introducing me. I just have to see, I'm not sure if the online people see me, but I say hi to the online people. So, and all the people here, it's my absolute pleasure to present here today. And I'm faculty at the University of Basel, Faculty of Psychology. And I'm a little bit of an outsider here because my research is in adult populations. And through this collaboration with Marc and his team, the early team, it gave me the great possibility as a co-investigator for the upcoming year, or currently in the early project, to expand my research also to younger populations. And as my background is translational psychotherapy research, and the great thing about doing translational psychotherapy research is actually that you're allowed and even encouraged to expand, because we really like, as translational psychotherapy researchers, work together, learn from other people, and integrate knowledge that we don't have. And that's why it's great that we have this collaboration that is made possible with the project from the BRCCH. I just said that I'm normally not doing research with adolescents, but I'm doing research also with young populations. And the two studies that we are currently running that I will present today, they are actually in young populations, and they are meant also to be translated to even younger populations. And when I start showing you the projects, you will understand that these are all interventions that are like scalable to other populations. So what is motivating my research? My research is mainly motivated that we have a lot of people that have mental health concerns, and we also have treatments for these people that work, but often these treatments don't work well enough, or we have people that drop out of these treatments, or that are not interested to use the treatments that we offer them. And as you see here on the slide, this is something that not only applies to adult populations, but also in a very severe way to young populations. And this motivated me in my working group for these two projects. One is a project where we use virtual reality to counter self-criticism, which is an important transdiagnostic factor. I will present you this project and another project that implements a single session intervention to counter academic stress. So let me start with the first project. As I said, self-criticism is an important transdiagnostic factor that is known to play a role in several mental health problems, but especially in depressive symptoms. Depression is something that is mainly treated with cognitive behavioral therapy, but we also know that cognitive behavioral therapy is limited, and is especially limited to treat these patterns that exist for a really long time. For example, self-criticism. So if I have myself very self-critical thoughts, I probably have them for a really long time. And as you see here in the pictures, they're always, you would see it here, the blue one, they're always with me somehow and speak in a way to me that is not really helpful for me and can be also really painful. And even if I don't have a depression and I have this self-critical voice, it makes me vulnerable to get mental health problems, and it's a good target, therefore, for prevention strategies to target self-criticism. So as I said, like cognitive behavioral therapy might not be the best thing to use with this critical inner voices because it's often associated with a lot of emotions, and there's research that shows it's better to work with emotion-focused therapies, techniques, as we have them in schema therapy. So the idea behind it is like that these critical voices that we have, that we kind of developed them while we were growing up and then internalized them. So this is like just something that I now said on the side, but what is important for you to understand is like that the difference between like the classical CBT approaches and the schema therapy approaches is that they are like an approach that is like maybe in a way more playful or uses techniques that are not just words like imagination or chair work. So these techniques that we have and that are established in schema therapy rely somehow on how well people are to imagine. And not everyone is good in imagining, so we have a limit here. So what you can see here, I try to walk you through. So we have like a situation here that we would also have in therapy, in normal therapy and not in therapy, in virtual reality, where you would have, you would like in an imagination, think about the situation that you've seen before, where like a child is confronted with someone who's, very critical. And then we would later have this, in this role play, we would have a situation where we have another adult that comes in the picture and protects the child and kind of enacts a new situation. And you probably, as you try to follow me, it's probably very difficult to understand what's actually going on in such a role play. And this is kind of the point. It's like, this is like hard to describe, and sometimes it's difficult to imagine. And even if you didn't understand how it actually works, I can show you how we did in our project to create these scenarios in virtual reality, and it might be far easier for you to understand. So normally in therapy, people have these imaginations or chair work, and what we do here in this project that we do together, that I do together with researchers from the University of Freiburg and the Max Planck Institute of Freiburg. We have a virtual reality scenario where we have a therapist sitting and where we have a patient sitting and have an avatar that plays this critical voice. And we have the possibility that the patient or the person who's using this scenario can take the spot of different avatars and feel what it's like to sit in every chair, and then also to fight directly. This one here is playing the critical part, and it's much easier for the patients or the people who are using this paradigm to navigate it instead of like having to imagine the situations. So what we did in this project, we created this virtual scenario and we tested it in a feasibility study with young adults that are like 18 to 24 years old and that were overly self-critical. So first we measured how self-critical the people are. Then we had this chair work where we brought them in a situation where they could confront the inner critical part that was embodied in a person that they choose before. And what I haven't said before is that we use the avatars in this scenario are built from pictures from the participants, one like an actual picture and one from their child. So they can actually really interact with an avatar that looks like they have been looking as a child. And so we used like one time this scenario, send them home afterwards, let them also gave them the possibility to listen to an audio tape of this session. And then after 7 days, we asked them again about self-criticism, because we wanted to first know, does it have an effect on self-criticism? We also asked them about depression, but here in this feasibility study, we first wanted to know, is it actually working imagination in virtual reality or chair work in virtual reality, because this is something that has not been done before. I would like to show you just very quickly some of the things the participants said. So that was very encouraging. People seem to like it, and they said it's a good opportunity to do it. Also here, it kind of, what you see here, it affected them, and they really felt they were in the situation and they wanted to interact with their inner child. What you see here is that it was also said that it's very tiring. And here's something that is really important. They said, I wouldn't have done it. So this is really important because it shows us this might be also something that might motivate people to do something that they would otherwise not do in real life. And this is something that we also know from research in phobia. So that really virtual reality can be a low threshold technique for people who would not go to therapy otherwise. This is like, as I said, we were in the developmental phase. We were also asking, hey, how were our critical avatars? Are they actually good, or would you like to have other ones? And so they gave us some ideas how we could change this. And we also asked them, because we have like a written paradigm, or that we guide them through this virtual reality. And they gave us some ideas that we might give them more time. And so we used this input to change the next version of our intervention. And just to sum this up, as you see here, another very encouraging comment from one of our participants. Yes?
One small question. I am not completely sure the role of the kid avatar.
Yeah. I can tell, so I can make that a little bit. No, it's like it's also complicated to tell, and I didn't want to go so far, but I'm really happy to I explain you. So the point is, like, if you would say, like, we all have our experiences, and through our experience we develop different parts, kind of, and we have like this child part, and we have the critical parent part. It's just called parent part, but it's by everything we kind of lived, and we have all this parts in us, and sometimes one is more activated than the other one. And the idea of schema therapy is to set these parts on chairs. And it's actually the part that has kind of all the emotions and the pain is the child part. And so you would have the adult part, that this is you, and this is the one that gets strengthened. You have the child part, and you have this critical part.
Okay, now
And yeah, so you're absolutely right. It was a bit messy how I explained it. So no, because it's like and then you kind of you look for the child part and you protect the child part. And in the end, for example, the avatar is going to be thrown in the trash. So it's really like figurative in a way, and also you can change the situations. So whenever something comes up and you're not with me, just raise your hand. I'm really happy to explain. So this is what we have done, and this is what we now will do. So we will move one step further and do a randomized controlled trial. And one here with 2 study centers, one at the University of Basel and one in Freiburg. And some of the things I read, these are actually the things that we learned from the feasibility study. So we have a little bit more, we tell them more to listen more to the tape, because we actually seen that we have seen that the effects get bigger the further you're away from the treatment. So something seems to be happening outside of the session. So we wanted to encourage this. And we for sure also have now a control group. And this is something that will be done again in a younger population, but in an adult population. But it's absolutely transferable. You could use the same thing with little adaptations in also younger populations. The second project that I want to speak about quickly is one that we are currently, that actually you're going to see it in the end of the talk, but I'm going to mention it now. So we started recruitment today. And it's based on the experience that many students have, or many students share, that they are stressed out, or that it's known, the research is actually accumulating that academic stress, it's a real issue, that this is a population, students are a population that have high levels of depressive symptoms, exhaustion, and also burnout symptoms. And especially also in this area, things like fear of failure, perfectionism, and self-criticism are an issue. And at the same time, we don't have enough resources for this population to counter these problems. In this field, it's known that something that is called like compassion-focused therapy might be something that works for to reduce depression, self-critical thinking, while also increasing self-compassion. What do I mean with self-compassion? I mean with this that you look at yourself with a non-critical voice, and that you bring to yourself an understanding for the difficulty of certain situations that you're in. And there's like accumulating research that this might be helpful for interventions in student populations. But so far, there's no research on digital interventions, or especially what we are testing in our study are so-called single session interventions. And what are single session interventions? The most important about it is that they are like structured, often done in one sitting. They're often delivered digitally, but they don't have to be. And they're based on elements of other therapies or supported, empirically supported treatments. And especially in young population, there's like more and more evidence that this is something that works for young populations. Because these populations, when they're struggling, when they're at risk, they want to have something that works now and that is accessible. And single sessions interventions, because they're online and often online or scalable, they are available and they seem to help in these kind of fields. And there's like evidence for depressive symptoms, but also for other symptoms. That motivated us because we saw we have academic stress. We don't have enough resources for students that have academic stress. And there seems to be these single session interventions that have very good results at the same time, low risk. So this motivated us to create this intervention. You see here the study teams. It's like 2 of them are like Sophia and Clara are students, master students that have did a really great job in like bringing this project forward, also with their own experience as students. And you see here, this is our website. And just to show you quickly, all of these single sessions, they have the same structure. They start with a peer testimonial. You see here, Circle is 24 years, history student. And there he would, like in the peer testimonial, he would describe his situation. The second part is like psychoeducation. We created here with the media center a little explainer video. The third part is like an activity. This activity is in our intervention is compassion focused. So they have a compassion focused exercise that is like guided. And the last thing is they get an action plan, and the whole thing is about 45 minutes. And everything is online, and they can do it in one sitting. So this is what we created for the intervention. And here, before I come to the end of the presentation, I show you quickly the structure of the trial. You see here, we have the one group who gets the intervention. The other one is a waitlist group. And the waitlist group will receive the intervention once they participated in the study and not before. The people who participate have a certain amount of stress, but are not, they're subclinical, they're students, subclinical. So we screen out people who are, have, for example, depression. They use our intervention, and then we assess our primary outcome, which is like academic stress or the experience of stress before and after, directly after the intervention, and then at the 1 week later. Additionally, we also measure anxiety and depression, and also want to see how compassion, self-compassion changes. And if this would prove to be effective in this population, that could be easily scaled up. Anyway, we created this intervention and it's available online. We will put all the material also on the open science framework, so anybody can use it, and it would be available for all students. Right now, the study is running in German, the German part of Switzerland. But as I said, everything can be adapted very easily. So spread the word. We are starting recruiting. And to sum up, what I presented you today is possibilities that we have with digital solutions to create low threshold interventions for young populations that have the promise to be scaled up and made available to a lot of people. So, and to end this presentation, this is not something that I do by myself. We have quite some collaborators on the projects, and also, once again, I want to mention the early team here that brought me here, and also the BRCCH who invited me to give the talk. And I think time is almost up, but if there are any questions, I'm really happy to answer them. Thank you very much. Yes.
One very, very nice question. How do you measure, I mean, for the first study that you mentioned, how do you measure selectivity?
Yes, we measured with a questionnaire, so like classical psychological questionnaire. It's like a questionnaire that is called to see. I mean, it doesn't matter how it's called, but just it's a lot of questions where statements are in. So, for example, if something doesn't work out, I beat myself up, or if I'm not good in something, I feel really ashamed, or something like if something doesn't work out, it's okay for me if it would be cool. And so, and in the end, you have a score. And this is something that we saw in the study, that before the answers are more self-critical than they are after actually this very short intervention.
My last question,
Yes.
is that like the avatar? So it's like the person can have like a picture of themselves as a child, and
Yes.
I guess integration into virtual reality. But let's say like this person that represents the criticism, etc. These are running out. That cannot be like for instance.
You choose it. You get a selection. So you have like a selection. So because like it's more like we have like this. You saw this man now. We have like a female that looks like a super strict ballet teacher, or like a bit like stereotypes. But now we also asked the people, and they told us like, yeah, but I'm not sure if it's really a person. It's more like a black cloud, and now, or like one said it's a monster. So that's why we did the feasibility, and now we gave the instructions to the programmer, and we are waiting for next avatars, and then you can choose.
Thank you.
I'm the principal investigator of, this slide is annoying, of the early study, investigating early signs, risk factors, and developmental cause of personality functioning impairment in young people. I'm very thankful to the BRCCH. They are funding this study. And I'm very thankful for all my colleagues in Basel. Without their work, this study wouldn't be possible. Also to Dorothée, who hosts us. Hosted us since August for 1 year, and to all the international partners who take part in this study. And today I'm going to talk about the project, the rationale of the project, and the current standings of the project. I try to pack in as much as possible for half an hour. So bear with me if I'm talking too fast, or if I have to skip some of the slides because we only have half an hour. I try to talk about everything that you see on the slides. So the rationale for this study is pretty easy. Personality disorders are among the most severe mental health burdens for the society. People with a personality disorder have a reduced life expectancy. The suicide rate is about 10%. Can I just keep talking or not? Not working. Die bei Zoom sehen es nicht im Vollbild.
Das ist gezoomt.
Ah. Doch, doch, hier ist schon eine.
Ja, nicht.
Ich habe keine Blumen. Normal, vielleicht wieder aufgenommen. Das ist manchmal so, wenn man jetzt hier auf Starten-Bildschirm starten geht, dass es trotzdem bei Zoom dann die komische Ansicht ist. Aber das müssen Sie vielleicht einfach ertragen. Ah, jetzt geht es auch gar nicht mehr. Ah. Aber jetzt ist irgendwie der Bildschirm nicht mehr. Der ist irgendwie eingefroren. Das kriegen die jetzt nicht angezeigt, ne?
Das ist das, was irgendwie ist.
Ah, das ist quasi der Zoom-Bildschirm. Ah, Entschuldigung, jetzt war ich ein bisschen dumm. Irgendwas ist ja mit der Projektion stimmt nicht. Das gefällt mir richtig gut. Ähm, aber man muss auf den Teilscreen gehen. Ah, ich habe das hinbekommen. Das ist wirklich verrückt. Okay, so we keep going. Personality disorders are among the most severe, not only mental health burdens, but health burdens, because people with personality disorders also suffer from high somatic comorbidity. And there's a suicide risk rate of 10%. And the burden of disease is comparable to Parkinson's disease and rheumatic disorders. And many studies found that having a personality disorder is an independent risk factor for adverse psychiatric outcomes and somatic outcomes. And so there's a really high public health relevance in studying personality disorders. Also, it's not only bad for the individual, it's bad for the society as a whole, because many people with a personality disorder are in a not education, employment or training status. So they're not able to contribute to the society with paying taxes and stuff. And they need support like invalidity pension, et cetera. And one study in the US found that they call it psychopathic personality disorder, which doesn't really exist as a term, which is close to antisocial personality disorders. And they found that they are responsible for 2.4% of the gross income of the US, because they commit crimes, they are held in prison, etc., etc. So, ist alles gut. Danke, yeah. So we came up with the idea, as I think prevention and early intervention is really important. We came up with the idea to really figure out how personality disorders develop. And we thought a good idea would be to conduct a prospective longitudinal study, to have a cohort of children and follow them up until they're 18 or 20 years old, to really figure out when and how personality disorders start and when we can track them. What you need to know about personality disorders is that there is a new concept of diagnosing personality disorders. We no longer have this categorical system of borderline, antisocial, narcissistic, etc. personality disorder, but there's been a complete shift towards a dimensional model of personality disorders. And this dimensional model integrates self-related and interpersonal personality functions. And they are identity, self-direction, empathy, and intimacy. Identity, having a coherent sense of self, having a stable sense of self, self-direction, having goals, being able to self-reflect, and being able to pursue your goals. Empathy, understanding other people, being able to take the perspective of someone else, and intimacy, being able to build close and mutual satisfying relationships. So we took this concept and developed self-rating questionnaires for adolescents and parent rating questionnaires for children to be able to grasp personality functioning as early as age 6. We don't want to diagnose personality disorders at the age of 6, but we want to use this concept and try to better understand when we can detect personality pathology using personality functions. Well, we wanted to find out, I'm sorry, this slide is in German. There's this group of 5 to 7-year-olds. Some go towards the green, which is good, and some develop towards the red direction. A lot of illicit drug use, interpartner violence, early parenthood, no job, suicidal ideation, etc., etc. And we wanted to find out which factors lead or which factors make these children develop to this rather unfavorable outcome. So our study design is having a large group of 5 to 7-year-olds and follow them up every 3 years until they're 7 to 19-year-olds. Until they're 11, we only ask the parents, because usually 8-year-olds do not fill out questionnaires. And once they turn 11, the parents, as well as the adolescents, will fill out a lot of questionnaires. We assess adverse childhood experiences, maladaptive traits, borderline personality features, general psychopathology, substance use on the side of the children, and we assess maladaptive traits, personality functioning, and adverse childhood experiences on the side of the parents. So this is ours. We actually do have 2 study designs. One is a classic prospective longitudinal study, and the other study design is an accelerated longitudinal cohort design. This is the cohort design. So we have different age cohorts, and we just follow them up for 3 years. But that makes it possible to follow up normative trajectories of personality development. And then we have a classic longitudinal study with T0, T1, T2, T3. We expect an attrition of 25%. So we hope, we aspire to end up with a cohort of 475 cases that we have been followed up for 12 years. And these samples are enriched with clinical cases because it's expected that 5 to 10% in the normative sample will have moderate to severe impairment in personality functioning. And then we will end up with very few cases that actually have personality functioning impairment. And we think that if we enrich it with clinical cases, the percentage will be a little bit bigger. And thank you, ChatGPT. This I tried to make this with ChatGPT. This is just a rough scheme of what we're trying to do. So we have the proportion in the cohort in percentages. This is about 80%, then 15 and 5%. The higher the bar, it means the more personality functioning impairment. And so you would have the highest amount in the unimpaired area. And this is just possible trajectories of personality functioning impairment. So you will have some who will develop personality functioning impairment from age 5 to 7 to age 8 to 10, and then they might stay in this cohort, or they will become even more impaired, and some will get better over time. So this is something that might be the result of this study, that at the end we have different trajectories of personality functioning impairment from year 5 to 7 to year 17 to 19. This just gives us information about normative personality development in different age groups and different age cohorts. This is the accelerated longitudinal cohort design. So as I showed you, we have 3 different cohorts, 5 different cohorts, 5 different age groups, but they all cross at one time point. And this gives this quasi longitudinal design, so we can compare and see if at a typical age, certain personality functions are more impaired than at other ages. This is also very schematic. We have, this is a little bit overwhelming, but I will guide you through. This is just our study schedule, our study plan. This is where we are now. We started at the end of 2022. This is just lit slot fra MEX is just the short for our partners in Lithuania, Slovenia, Tanzania, France, Mexico, Turkey, Russia, and Romania. These partners will conduct the same studies, but before they can do that, they need to culture adapt and translate our questionnaires. So this is what they needed to do before they can start the longitudinal study. And it's not very easy. You have to have the questionnaires, you have to translate them, back translate them, do some pilot and beta tests to see if it really works in the given culture before you can start the data collection. And the aim is to have this joint database with a group of 660 clinical cases that were all assessed with culture adapted instruments in the same way, so we can pool the data and have cross-cultural comparisons concerning personality functioning, etc. The plan is also that we present on conferences each year, which we did and which we will do. And once the questionnaires are ready for use in each country, they will be published. So while we conduct this study, clinicians in each country can already use the questionnaires. That was one important aim of this study. The next slide is just what we plan to do in the future. This is going to be the next 4 years. We're going to apply for further funding to be able to further conduct the studies and do our follow-up tests and enrich the database, and again present data on conferences. One of the main aim is also to have, as I told you, this database, which we are responsible, we in Basel are responsible for the maintenance of the database, but also we want to facilitate clinical translation to make everyone every partner an expert in their country. So they have these questionnaires. They can then disseminate their knowledge in the country, which Anna will maybe tell you about for Slovenia, because she's here from Slovenia. I'm very happy about it, how they do it in Slovenia and what maybe changed in the past years concerning personality disorder development. So this is really one important part of the study, to support the international partners, to support early detection of personality disorders in different countries. I think I'm going to skip the next slide so we have some more time to discuss the study results. Recruitment started in August 2023 and is ongoing. We have the study site in Basel, which is conducting the normative study to go to schools and do social media advertisement to recruit as many people in the normative sample as possible. We have Bern, Zurich, and nearly St. Gallen, the clinics for the clinical recruitment. And it's been a rough ride the past 2 years to really recruit all the participants. And it's also very complicated because the ethics, they want that we have a signed document in paper format from the participant who is willing to participate. So this means we have social media advertisement. People see the study and say, hey, yeah, I want to participate. So they leave us their contact data. We then have to call them, tell them how the study works. We tell them that we send the study procedures in an envelope with a prepaid envelope to send it back to us. So they get it home, they sign it, they send it back to us. And once we have it, we send out a link so they can access the assessment platform. That is really complicated, but we couldn't do it in another way. So right now we're doing hopefully the last part of the baseline assessment, and we hope that we really end up with 1,500 in the prospective longitudinal study. So far, we have acquired a total sample of roughly over 2,000 people, most in the normative sample, but also almost 200 already in the clinic. The mean age of the children is 9 years, and the mean age of the parents is 42 years. Mostly, this will just be descriptive data so that you get an idea where we're standing right now. We have 516 adolescents between the age of 11 and 19. You see, like, the age groups are a little bit skewed towards 11 to 16-year-olds. We just recruited almost 150 7 to 19-year-olds that didn't already fill out their questionnaires. In the clinic sample, we have a very high proportion of 14 to 16-year-olds and not so many in the other age groups. So this is also a reason why we also included the clinic in St. Gallen to help us with the clinical recruitment. So far, we have 1,679 parents. The numbers differ a little bit because we have quite some siblings. So we have more children than parents in the study. Again, it's mostly from the normative sample. And these are the actual numbers of children in each age group. You remember we wanted to have 200 in each cohort for the accelerated longitudinal design, which is achieved in most of the cohorts. We have much more in the 8 to 10-year-olds, which isn't really a problem, but we didn't want to tell people that were willing to participate that they're not in the right age group, because it was hard to track, really narrow down the age groups with the advertisement on the social media campaigns. And this also gives us the opportunity that if we cannot manage to really achieve 1,500 5 to 7-year-olds, we can merge both of these groups and have a 10-year follow-up for the 8 to 10-year-olds to achieve the amount of participants we need. So you see in the clinical age groups, recruitment is a lot harder than for the normative sample, but we hope also with another effort in the next months that we will come up with the number needed. So this is just a description of the sample. The adolescents in the clinic sample and in the school sample are roughly at the same age. The gender is a little bit more female than male. That's something that we find in almost every study, that women are somehow more interested in taking part in studies, but also in the clinical sample, it's a little bit less than 50% because we recruit in the AHA Basel, which is a facility that is only for boys. So I guess that is the reason why there's more boys in the clinical sample. And overall, you can see there's a significant difference in overall mental health problems when you compare the school sample to the clinic sample, which is kind of intuitive. If you look at adverse childhood experiences, in the total sample of 513, you see that there's 15% that say they have experienced emotional abuse, 6% physical abuse, 6% sexual abuse, 10% emotional neglect, and 14% physical neglect, which are numbers that kind of replicate what we've already known from other studies. What you can see here is that 70% say that they haven't experienced any adverse childhood experience, and 12% have more than one type, 7% more than 2 different types of childhood maltreatment, and 4% more than 3 types of childhood maltreatment. And that's something that we've also known from other studies, that it's more likely to experience several different types of adverse childhood experiences. When you look at the other slide, you see that the vast majority in the sample has neither PTSD or complex PTSD, but 6 or 7% in the sample currently suffer from PTSD or complex PTSD. What you see is that there is an association between the sum of childhood maltreatment and complex PTSD, which is something that we've already known, that there's this kind of dose-response relationship. The more adverse childhood experiences you have, the more likely you are to suffer from mental health disorders, and more severe mental health disorders, and also complex post-traumatic stress disorder. That's what I wanted to say. You can also see that if you compare the school sample to the clinical sample, this is again only the adolescents, you have a significantly higher amount of adverse childhood experiences in the clinical sample than in the school sample. Sometimes, in most cases, double or even 3 times as many adverse childhood experiences. If you look at the levels of personality functioning, at least moderate impairments, this means the highest 15% percentile. You also see that in the clinical sample, you have a larger amount with at least moderate impairments in personality functioning, and it's significant for all domains in personality functioning. If you look at maladaptive personality traits, you see also that there's a higher amount of maladaptive personality traits or impairment in personality traits in the clinical sample compared to the school sample, except for anancastia, which makes sense because, as I told you, we recruit in the AHA Basel, which is a facility for kind of a juvenile detention center. And these boys are not really known for being very anancastic. They should be more, I guess. So there's not really a difference, or it's even higher in the school sample than in the clinical sample. But we've also found in a study before that the anancastia domain doesn't really work well in a juvenile population. If you look at the children aged 5 to 7, again, it's only parent report. You see there's an amount of mental health problems measured with the SDQ, a total of 12 almost 13% suffer from any mental health problem. And you can see that the borderline personality feature scale for parents, you have 7% in this age group with borderline features. Again, we don't diagnose personality disorders below the age of 12. It just gives you an idea that some of these problems might already be apparent at an age of 6, 7, or 8. If you look at personality functioning, you see that there's a bigger proportion with at least moderate impairments in this age group. I don't know what we make of it. That's why we conduct this prospective longitudinal study, so we can see the trajectories of personality functioning impairment, and if it really speaks for an impairment in personality development at this age. Interesting enough, at least moderate impairments in empathy, this is 1/3 of the normative sample where the parents say that there's some impairment concerning empathic functioning. I don't know what we make of it. Maybe we'll see what the different developmental trajectories of these children will be. But also almost 25% have parent-rated at least moderate impairment in intimacy functioning with close relationships, with trust, etc. Yeah.
Just ask something. How are the parents asked about empathy?
So one question might be, my child is really empathetic, or is really cooperative, or cares for others, or my child is really moved when he or she sees that someone cries. My child tries to understand what's going on when we have a conflict or something like that.
Yeah, that's really interesting, because I'm really interested just to look at the items, because I kind of wonder if it might be also driven by high expectations, you know? But it really depends how the question is phrased. If you would think that a kid at a certain age would be able to be more empathetic, maybe age appropriate.
It's interesting because the SDQ also measures like conduct. This is towards conduct disorder, but it also asks empathy questions, like behaves well or is cooperative in a group or cares for others. And this is also rather high, like 20%, but it's also easier for parents to rate behaviors or a lack of behaviors than inner feelings of the child. So it's easier to say, yeah, he's aggressive or he fights with others, than it is to say, well, he doesn't feel well in his skin or something like that.
Yeah, I think the same.
But maybe also the levels of personality functioning questionnaire for parents is rather sensitive and not very specific. We don't know.
Yeah.
Maybe. Which is kind of good, because we want to really grasp the ones that might suffer from something and not miss it. So I don't know yet. This is the personality traits. Interesting, negative affectivity, 40%. Has a lot of mood swings, is very irritable. These are questions that we ask, which to me seems really high for this normative sample that doesn't seem so affected. But I don't really know what we make of it. Maybe it's also very sensitive questionnaire, but also I think having conducted some of the phone calls and having talked to the participants, we don't have a healthy sample. We know the parents, yeah, I know I'm depressed or my child has ADHD. So they seem to be interested in the study because they know that something is going on in their family. So maybe these are actually the impairments in this sample. I don't know. Yeah. like obsessive compulsive behavior, like you're really perfectionist. You want to do it that way, and you need to be like it needs to get done, and unless it's perfect, you won't stop. So that is interesting. It's pretty high in this sample. So this is just the parents. From the parents' side, we also assessed the mental health problems on the parents, and there's some depression, anxiety. This is also, I think, quite representative. We found that in others normative samples before, that this is the amount of mental health problems the general population has. Again, childhood maltreatment about as often as for the adolescent sample, kind of 12 to 15% of adverse childhood experiences. If you look at the parents, we also assess personality functioning impairment on the side of the parents. You see that almost 15% have at least moderate impairment in personality functioning. And if you look at associations between childhood maltreatment and impaired personality functioning and mental health problems, you see that there's a rather strong association between overall childhood maltreatment and personality functioning impairment, and especially strong for emotional abuse and emotional neglect, which I think is really important. Is an important finding because we often talk about the kind of active kinds of childhood maltreatment, such as physical abuse or sexual abuse, but emotional abuse and especially emotional neglect, not having received something that you should have received, also might have a really unfavorable effect on personality development. So this was the very quick and rather fast overview of our study, the current standing of the study. Again, thank you very much to all my colleagues who make this study possible here and abroad, and to the BRCCH for funding this study. And I'm happy to introduce Anna from Slovenia, our dear partner, who's conducting the early study in Slovenia, and is happy to share her experiences with diagnosing and treating personality disorders in Slovenia.
So hello to everyone. Hello to everyone on Zoom also. I don't know if they can see me or not. Thank you for inviting me. I'm very happy and grateful to be here today and to exchange ideas and knowledge. My name is Anna Gregorec. I am mainly a clinician. I will be finishing my clinical psychology residency in a few months at the University Clinical Center in Maribor, and I am also trying to do some research. So I'm a PhD candidate at the University of Ljubljana. Today I wanted to talk about adolescent personality disorders in Slovenia. In particular, I wanted to talk about the background that led to our interest in personality pathology in adolescents. And I'm going to briefly present some of our currently ongoing research that mainly includes the early study and some other projects. And I will briefly mention our current diagnostic practice at the field of adolescent personality disorders. So this is our cute and small town of Maribor, where I come from. I work at the pediatric clinic at the unit for child and adolescent psychiatry. And maybe what I wanted to stress today is that Slovenia is quite a small country, but recently we've been facing an increase in mental health issues and consequently also a shortage of clinical psychologists and child and adolescent psychiatrists. So we've been pretty swamped up with work, which leaves not much time for doing proper research. So in the past few years, our main goal has been to adapt and validate certain new and up-to-date questionnaires and psychometric tools to measure mainly personality pathology. So unfortunately, recently mental health problems in Slovenian children and adolescents have been unfortunately on the rise. Many young people report there has been an increase in youth seeking help because of anxiety symptoms and depression symptoms and psychosomatic symptoms also, such as headaches, sleep problems, and stomach pains, which can be easily linked to or are an indicator of emotional distress. So the data from our National Institute of Public Health shows that in the recent years, there's been a large increase in first-time psychiatric visits. So basically in the period of 2008 and 2015, first-time visits for mental health issues like behavioral or emotional disorders increased dramatically by 26% in primary care and 70% in secondary care. And also, as I think it's the case in many other countries worldwide, there has been a steep increase after the pandemic, actually a 41% first-time visits in tertiary care, that is emergency care. So a recent study that has been analyzing the data from our National Institute of Public Health has shown that after an initial drop in first-time visits in 2020, all levels of mental health care saw a sharp increase in demand in 2021 and 2022. That's after the pandemic, of course. So our waiting times actually exploded. Youth that was referred under the label of very fast and urgent has to wait now 4 to 7 times longer than it did before the pandemic. But the authors noted that actually the primary care visits accelerated around 2017 for some reason. So the overall increase is not entirely due to the pandemic, but the pandemic clearly worsened things for us. Social media also probably one of the factors. So what we've noticed mostly is an increase in suicidal ideation and suicide attempts during the pandemic, but not so much due to the closures of schools, but more due to the duration of the pandemic, which suggests that the prolonged stress may be a key driver for these presentations. Also, we found out significant social inequalities where children and adolescents from lower socioeconomic status present with more mental health issues. Mainly, they report lower mental well-being and they're at greater risk for depression. So according to one of our studies in regards to mental health in the mid-2021, the surveyed adolescents rated almost half of them rated their mental health as either fair or poor, and a large majority reported constant stress or pressure. 70% of them had unexplained physical symptoms, and 64% attributed those symptoms to their poor mental health. So if we look at the key mental health trends in Slovenia, we see that most of the youth that's in treatment, either outpatient or inpatient in Slovenia, presents with emotional and behavioral problems, anxiety, depression. We have a lot of eating disorders and psychosomatic symptoms also, but self-harm and suicidality remain major clinical concerns in adolescents and also children sometimes, unfortunately. But what I wanted to talk about today is what we observe from our clinical practice, and that is that the struggles that youth presents with that comes to our clinics, not all of these struggles can be neatly categorized into well-known or traditional diagnostic boxes, because what we see in clinical practice is that what these young people have in common is that they report a lot of emotional dysregulation that goes across and beyond all the traditional diagnoses. So we see a lot of predominant negative affectivity. We see a lot of temper tantrums in younger children and acting out in adolescents. There's a lot of impulsive and self-harm behaviors. The youth reports on major interpersonal issues, such as being rejected by their peers, their struggles with intimacy, or the lack of their mentalization skills. There's also suicidal behaviors on the rise, and all those symptoms kind of explain the comorbid diagnoses that are very frequently present in the clinical setting. So they present with mixed internalizing and externalizing symptom profiles. So if we look at recent literature and studies, we see that these traits that I just stated, or these symptoms, presentations, manifestations, however you want it, they do indicate personality pathology. So again, these problems do not emerge only from the common disorders, but are a manifestation of a broader personality functioning, like, for example, different social and relational vulnerabilities, such as difficulties in identity formation, emotional regulation, empathy, and interpersonal functioning. These are recently or increasingly recognized as central elements. So that's why we are very grateful to be contributing to the early study and trying to assess and put emphasis on the dimensional personality functioning frameworks rather than strictly categorical diagnosis, because by assessing personality functioning, we hope to capture the underlying distress and maladaptation in youth that goes across and beyond traditional diagnosis. So we have two goals. Mainly, the first one is early detection. As Marc said, we assume that we can see certain indicators, not personality disorder per se, but certain indicators of maladaptive personality functioning in children aged at around 6 years. So our main goal is to identify maladaptive personality functioning early, so we may prevent them from crystallizing into more rigid or disabling structures later on or in adulthood. A lot of recent studies have emphasized or found out why the personality functioning helps explain symptoms and comorbidity in adolescence. So personality functioning can actually be seen as a sort of a transdiagnostic core, because these capacities that Marc talked about, so identity, self-direction, empathy, and intimacy, these capacities underlie how young people regulate affect, form relationships, pursue goals. So impairments in them naturally produce a wide range of clinical presentations rather than a single diagnostic picture. Also, measures of impaired personality and functioning can distinguish well between clinical and community youth and track severity. So higher impairments in personality functioning usually mean greater overall psychopathology burden and more complex clinical presentations. Also, we know that impaired personality functioning can co-develop with and predict comorbidity. So higher levels of emotional dysregulation, disinhibition, and social dysfunctioning commonly occur with multiple disorders. And we know that levels of personality functioning impairment can account for why some symptoms cluster together and why comorbidity is common. Also, personality traits and functioning together, so the criterion A and criterion B of the new dimensional models, together explain more variance in outcomes than traits alone. And levels of personality functioning actually have a great clinical utility because they can identify youth at risk for chronic and complex outcomes. So in Slovenia, we have been using some dimensional psychometric diagnostic tools for diagnosing or at least screening for personality pathology in adolescents. We have 3 valid, adapted, standardized psychometric tools, questionnaires that are a result of our previous collaborations with Marc and his team. So we have the assessment of identity development, the levels of personality functioning questionnaire, longer version, and the OPD that's measures second personality structure dimensionally also, but more from a psychodynamic point of view. Before that, we only have the personality assessment inventory. I don't know if you know it, but it measures symptoms more than actual personality. And we do still use the Rorschach, not with small children, but with adolescents, but we do not use it as a projective tool, but we are actually assessing, or our scoring system is very psychometrically and empirically derived. It's called the performance assessment system. It's relatively new, and it's developed in USA by Mayer and his colleagues. We also have the inventory of children's individual differences. This is a questionnaire that measures adaptive personality traits according to the Big Five taxonomy, but we do not use it in clinical practice. We are just using it now for the purposes of the early study. So as you can see, we do not have anything to measure the maladaptive traits, so we're validating and standardizing this now, and we do not have any parent reports. So the early project in Slovenia, I won't talk much about the design of the study because it's practically the same as Marc told you earlier. As he said, we have to first culturally adapt the questionnaires, which is a lot of work for a few people, but we have managed to do the pilot study just to check how the questionnaires behave and if we need to correct anything. So we did that, and we are currently in the process of main validation study. In the future, we're also planning to joining the longitudinal study, longitudinal design, probably not the proper longitudinal design, but at least the accelerated cohort study. So the pilot study we did, we checked the levels of personality questionnaire short version, the parent report version, and the maladaptive traits questionnaires, both the self-report and parent report version. So we want to adapt and standardize those. We did a short, small pilot study on 67 participants. 35 of them were students from a school sample, and 32 of them were our patient, either from an inpatient or outpatient unit. And as you can see, what I talked about earlier, a lot of them, most of them actually had comorbid diagnosis of mixed internalization and externalization symptoms. And we do specify emerging personality disorders. We do not diagnose personality disorders in Slovenia under the age of 18. That's mainly because of the stigma and old traditional categorical types of diagnosis. But we do keep in mind that personality pathology is usually hidden behind this comorbid diagnosis. Okay, so I will just briefly mention that. Our pilot study showed good psychometric properties. Our scale reliabilities were mostly good. We did have some issues with certain subscales, for example, with the continuity subscale in the parent report version and the disinhibition domain in the maladaptive traits questionnaire. This one was problematic both in the self-report and the parent report version, but we found out that this was mainly because our translation of the items wasn't good enough, or we had a difficulty grasping the cultural meaning in our language. So we did correct that and ran some and did some additional beta tests, and the scale reliabilities for the continuity domain and the disinhibition domain improved significantly. So we started the validation study. I think I'm just going to skip these two because we're running out of time. So our current validation study procedure is recruiting children and adolescents aged from 6 to 19 and their parents. Our clinical sample consists of our inpatient and outpatient unit, and we also managed to recruit some of the nearby outpatient clinics. Our total target sample is 500 participants, which is a lot for Slovenia, and we always have issues with gathering enough of data, but it's been going slowly, but we've been getting there. So the test battery for children aged 6 to 11 mainly consists of parent reports. So we give them the maladaptive traits questionnaire, the levels of personality functioning. We wanted to use the SDQ, but we are applying Achenbach scales. I don't know if you know them. It measures emotional and behavioral symptoms, problems. We use that routinely in our clinical practice, so that's why we decided for that one. And with the clinical sample, we also collect other data from other psychiatric or psychological assessments. We do an in-depth clinical interview, unfortunately not standardized because we do not have STIPO or SCIT standardized, but we do like an in-depth analytical diagnostic interview. And the test battery for children aged 12 to so adolescents basically consists of self-reports and parent reports. Pretty much the same as I mentioned earlier, it's just that the adolescents also fill out the personality assessment inventory. Currently, we're also writing a paper out of the data, some parts of the data we currently gathered, and we are looking at the associations between personality traits, the adaptive side of personality traits, and impairments in personality functioning in a clinical sample of Slovenian adolescents. So we currently have 80 adolescents, but are still gathering data. We put them in 3 diagnostic groups: internalization symptoms, externalization symptoms, and comorbid symptoms. And we're measuring or using the levels of personality questionnaire and the inventory of personality of child and individual differences that measure personality traits. The results, the numbers you see have been calculated when we had about 60 adolescents for the purposes of a poster we did in the summer. So we found out strong associations between the personality functioning impairment, especially the self-domain, and personality traits. We found out that self-direction impairment is correlated with higher distractibility, with low positive emotions and low extroversion. And identity impairments were correlated with high negative affect, low sociability, and low positive emotions. So basically across all domains, higher impairments in functioning were most strongly related to traits reflecting emotional dysregulation, disinhibition, and low sociability. Okay, and I'll just briefly mention that is another project currently ongoing at our unit. I only take a small part in it regarding the questionnaires, but I think it's interesting and worth mentioning. If anybody is interested or wants to look it up, you can just Google it or contact one of my coworkers. So basically, the Certain project aims to certificate tools for ethical, safe, and transparent use of artificial intelligence. And what we're doing is we're recruiting adolescents aged 12 to 20 with symptoms of anxiety, depression, or borderline personality disorders, healthy controls also. And we are conducting a tablet-based pre-screening interview with a chatbot. That's our chatbot. Her name is Frida. And basically what Frida has to do, she collects multimodal digital data like speech and language subtleties, facial expressions, body movements. We also have a physiology measure, I think the skin conductance thingy on the finger, and also indoor air quality. Besides that, we're administering validated questionnaires. And the main goal is basically to link digital markers with clinical diagnosis. So we would like to build a multimodal database to support development of explainable artificial intelligence for early detection of youth with mental health risks. Yeah. So that's it. Thank you for listening.
Also, there's a question from Mark.
Oh.
Online. I just will read it. I see that you have some very valuable data. What I would like to ask is, do you think ACE scores are high in your results? Emotional neglect and abuse also come up high in my studies. Could this be because we screen with CTQ? I encounter really high prevalence in CTQ screenings. As I haven't compared it with another scale, my comment may be somewhat speculative.
I don't know if I understood the question correctly. I don't know of any study that would say that the CTQ generally overestimates emotional neglect and emotional abuse. I think the questions are pretty straightforward. I've often been called names. I've been often screamed at. Nobody took care of me. I feel that nobody loved me. I think if you've experienced it, you'll answer it like this, and if you didn't, you wouldn't. So, I don't know. It's just one of the most widely used questionnaires for assessing ACEs. And we really, since we have like 8 different partners in different languages, we really wanted to use questionnaires and instruments that are available in all of these countries and all of these languages. And this is true for the CTQ. And we wanted to be able to assess different adverse childhood experiences, and not just possible traumatic experiences as you can measure with the CATs. Because we don't think that having witnessed a car accident or being robbed will lead to personality dysfunction, but cumulative ACEs will. So this is why we use the CTQ.
Thanks.